But to introduce Dr. Michael Hogan, who comes with a whole page of acronyms, if I can go back to a previous metaphor. But let me say this, that as Commissioner of Mental Health for Connecticut, Ohio, and New York State in his career, that's plenty of recommendation and introduction there. His accolades are many, and I can assure you, prestigious as well as plentiful. You can read his bio. Let me say this instead about him, something that I think we need to consider as we hear what Dr. Hogan has to say next. I was privy to I guess we'll call it a value-based level 3 discussion at cocktails last night. And I want you to know that these guys live and breathe this stuff. In that discussion came up Nash's theory, equilibrium theory, where if you look at the strategies employed in trying to achieve these reforms and how we can get all the various differential perspectives on this problem, may very well be what works. This was not your usual cocktail chatter, I think. One thing I can point out about Dr. Hogan is this, that very often in the discussion came the phrase moral imperative, ethically, these are not discussions that I think I grew up having at cocktail time. I think that the most salient thing that Dr. Hogan had to say was that his opinion is now no longer beholden to management nor public opinion. And for that, I think we should welcome Dr. Hogan.
So, thanks. You may wonder, like, so what is it worth? But that's another question we'll find out the answer to. I want to sort of ask a little bit who you all are, because I come from a little bit of a different place, and it will help me maybe to be a tiny bit more relevant. So I just want to ask for a show of hands on 2 questions. The first question is the self-identification and arbitrary categories. The first category is consumer, family member, advocate, clinician, direct care provider, board member, or manager. So, consumer, family members, advocates, okay, a little bit, not so much. Clinician, direct service provider, not so much, not nearly enough. Board member, executive, not willing to disclose. Okay, so we have sort of a leadership-oriented crowd. And then the second self-identifier is primary interest in IDD, behavioral health, healthcare. So primarily IDD, primarily behavioral health. Not so many of my people. Primarily healthcare. Okay, pretty diverse crowd. Well, my talk in a way is it's sort of the digestive that follows Jason's remarks. And he stepped out for a minute, but I have to say, having worked directly and been in the trenches and occasionally gone toe-to-toe with Jason, you might question his direction and tactics. You cannot question his commitment and his effectiveness. So we are, as a state, fortunate to have strong leadership that he represents at these times, even though some of the details are going to be a little bit painful. Here's my clicker thing. So I should start a little bit off by sort of where I've come from. So you heard about like 25 years trying to run state mental health systems. The last 5 or 6 of those were in New York. That caused me to give up. I spent roughly 10 years before that, and these are not sequential times because I'm not going to be as old as this sounds, but I spent the first 10 years of my career primarily working in developmental disabilities. Did a doctorate at Syracuse with Bert Blatt and Wolf Wolfensberger. Then somehow transitioned from DD into mental health, and in the last 8 years I spent also my time on the board of the Joint Commission, and much more concerned about the world of mainstream healthcare. And I've lived for exactly the first month I had responsibilities in mental health was the month that my kid sister, who was on a full academic scholarship at NYU, developed schizophrenia. So my journey is like, it's kind of like that, just to give you a little bit of sense of where I'm coming from. So this, in a way, like this is Heather's acronyms, but with a picture of them, just a sort of a visual sense of what is going on in the environment that we're in. These many different, large and potent changes, all coming from different directions, all with different time frames. Some of them moving in different directions. And I think a great example of that was the conversation, sort of at the end about moving into a more rigid, rigorous fee-for-service reimbursement system in DD, very rapidly, full tilt boogie, while looking ahead to phase 3 value-based. This is moving in opposite directions. So the thought here is really, how do we cope with all this? I will say, I'm not going to give you the answer to this, but I'm going to suggest that a lot of where to go and where to cope has to do with sort of attitude, how we work with our people, our internal approach to organizing our team, and not finding the one magic outside answer that's going to solve the problem. And I can sort of sit down now because that's the talk. I will go through, maybe to illustrate this a little bit, what I describe as 4 megatrends that are wrapped up in all those different acronyms. And different people might see different megatrends in there. This is just my parsing of those big trends. The integration of health and behavioral health care, and we might add in a way disability care as well here. So the notion that we used to live in our separate worlds, and now we're being thrown in large pools together. So integration is a first megatrend that is perhaps most pronounced with respect to the world of mental health, where it used to be standalone, but now it's increasingly delivered in mainstream health settings. And the question also of whether this integration approach ever gets to population health, social determinants, and those kind of issues. So that's a first megatrend. The second megatrend is data. Data and communications in all of its forms, HIT, EMRs, and increasingly, and Jason's last example is a good illustration of this, the use of big data to try to solve problems in healthcare. We sort of go from a private closet industry to whoosh, that thing in Star Wars where they hit the button and the stars all go. Is sort of the data image here. Second megatrend. Third megatrend, this is a bit arcane and esoteric, and we're really not particularly paying too much attention to it in this room. But at the national level, this thing is exploding. The implications of precision medicine, which has to do with, I'll give some examples of this, treatments that are specifically for our epigenetic makeup, and not for any other person. And some signs about where is this and where is this going, and so on. And the fourth trend is really the one that Jason has spent most of his time explicating, and that's that both management of care or managed care on the one hand, and moving to value payment on the other. Now, for each of these trends, I want to suggest several things that are in conflict. The first is, I see each of these trends as inevitable. Absolutely inevitable, inexorable, steamroller, going to happen on the one hand. But I'm going to also say that I think we understand very little about the endpoint, about what the path is going to look like, and which flavors of these big mega themes we're going to end up with, which goes back to the same juxtaposition of blinding pace and diversity of changes that we're dealing with. The directions are kind of clear, but the implications are not at all clear. So we see this with respect to integration. I mean, one theme for this to some extent is the most important and the least important, is that people would rather go to one place to get most of their care. In the case of mental health, as my mother would say, I don't want to go to the shrink. You know, I want to get my help for depression with my doctor, particularly when going to the shrink, metaphorically, takes you in a separate room with a lot of baggage attached to it. I'll sort of quote my sister, who in the course of her first day hospital admission was feeling a lot of pressure to participate in community care, because this is what you're supposed to do. And she said to me, Mike, everybody in town knows that those places are for losers. This is from the mouth of somebody who is entertaining going to those places. So that integration is a good thing, because it has the possibility of maybe turning the temperature down on the stigma attached to separate care. One of the dirty little secrets about why payers like integration, and I'm not denigrating Jason's intentions or anybody else's intentions that's a payer, but this shifts the risk. So once you're in managed care, you do not have to go back for a deficit appropriation, because you've shifted the risk to somebody else and it's their problem. So consumers like it, but much more importantly, people that are paying the bills like it, because the risk has been turfed to somebody else who's got to deal with that uncomfortableness. There are also big trends, most of them implicit in the Affordable Care Act and other financing trends to force integration. Like, for example, it turns out that the big spend or the big cost associated with behavioral health conditions is really not for the treatment of behavioral health conditions. The big cost associated with behavioral health conditions is the excess consumption of medical services by people who've got behavioral health problems, which leads to readmissions, more visits to the PCP, more ER visits, et cetera, et cetera, et cetera. So that's a little bit of a different frame to think about cost. And we see markers of the inevitability of integration in New York. It started with health homes. This is a quote from Jason early on. It may not be all right, but the goal of getting everybody in a plan, number one, and number two, each plan having full benefits, which is a different kind of spin. This is not everybody in a vanilla managed care plan. For example, with DISCOs or with HARPs, the mental health version of that. People who have a dominant health characteristic of this are in a plan with other people who have that dominant health characteristic, but their pharmacy benefit is there, their medical benefit is there, their hospital benefit is there, the community long-term benefit is there, et cetera, all in one place. The second marker of integration. And then further down the road, and this is sort of hard to pay attention to now when we're focusing on these early stages of trying to figure it out in survival, but New York's $100 million SIM award from the federal government that promises to deliver advanced primary care across the state of New York over the same time period that we're rolling out all these other changes. And that this is a little bit of an editorial. And then as a kind of an afterthought suggests that advanced primary care will include behavioral health. Like we don't do it until we get them right. So integration, I'm thinking of, is inevitable. And of course, integration means different things to different people. It means one thing to the payer, it means another thing to the provider. It means something very different to the consumer of services. But this is moving very fast, but at the same time, it's conflicted and it's problematic. So, for example, the plans out there, don't get it yet. We shouldn't expect them to get it because for the last 30 years we had it. We didn't let them touch it. But now they're about to get the whole enchilada. So that's going to be interesting and complicated. And I think we'll hear after lunch a little bit about some of the critical success factors in moving in that direction. There's also sort of evidence of the payer world not getting this. So two of the most important pieces of mental health legislation, the two most important pieces of national mental health legislation, both in the last 10 years, are first the federal parity legislation, Domenici-Wellstone. We're talking about an odd couple, Paul Domenici and Peter Domenici and Paul Wellstone. But then second was the Affordable Care Act. Well, how is the Affordable Care Act big mental health legislation? Well, it's big mental health legislation because it says that mental health parity legislation essentially applies to all the health care coverage in the United States. But if you look at the settlements by New York's Attorney General Eric Schneiderman, by now until they have 6, 7, I don't know how many plans for failure to manage their mental health benefits in a way that really is parity, shows that the marketplace still hasn't completely gotten what is the national expectation. And at the provider level, integration is new and hard, but it would be hard even if all the dimensions of it worth changing simultaneously. Nobody was trained for this. Nobody was trained for this. No? So we were all trained in our silos. We got, whatever our discipline is, and most of us have moved, way past honest work here. But for those, a lot of us did honest work at some point in time, and we weren't trained to work in an integrated context. And the health home thing in New York, well, that's been a bumpy road, right? It's been in part a bumpy road because the design is so complex, the goals are so complex, and it's now been overtaken by 14 other bigger kind of initiatives. So it's not that it doesn't have value, and it's not that it won't be a critical component in the future, but a very bumpy road. And this is just a little a citing from the mental health world of integration. Collaborative care, which is a particular approach to integrating behavioral health into primary care, is perhaps the best established approach to organizing care in healthcare generally. With now 80 randomized controlled trials around the world with depression and kids and ADHD and anxiety. So an approach to care for common mental disorders in primary care. What percentage of patients after 80 plus randomized controlled trials, what percentage of patients in primary care have access to collaborative care? My estimate is 2%. So this comes for a whole variety of other reasons, the regulatory and payment obstacles, the fact that we weren't trained for it, et cetera, et cetera. And then, I would really like to go off on this whole other thing because it's one of my passions these days. But it goes to the question of moving beyond healthcare into prevention kind of approaches, like, for example, suicide prevention. I'll do my rant here a little bit. So 50% of the patients that died by suicide saw a GP in the last 30 days. Among old men, it's 75%. 30% of the people that died by suicide had seen a therapist in the last 30 days. In a number of different states, we've seen this 20 to 25% of all the people that died by suicide were in community mental health care. And we don't see it as our job. It's like public health does that. They have these coalitions and they go to meetings. It turns out that this is a problem in our healthcare neighborhood. If you're interested at all in that, go to www.zerosuicide.com, where we built for free all the tools that are needed to do good suicide care. And I'm headed to Washington tomorrow for a meeting with some of us that are working on this with about 10 different health plans to try to have a conversation with them about accepting they're beginning to step up and accept responsibility for this. So integration is inevitable on the one hand, but it's going to move in uncertain fashion, all of which leads me to conclude that integration is inevitable, but it's also simultaneously going to be a long and bumpy road, as we've already said. So, comparable examples with each of the other three megatrends that I described, sort of HIT and big data. Well, HIT and, not HIT, but IT and big data has won in the economy in general. I mean, if we look at, I just looked at an article from Forbes that looked at the 10 largest companies by number of employees in 1955 and then in 2010. So 1955, it's GM and it's Chrysler and it's Amoco, and in 2010, and this is not revenue, this is number of employees. It's Walmart and Target and Google and Cisco, so dominated by IT and data companies, and by companies that use IT and data to stage sales and other things. So, in a sense, healthcare is the last refuge from data interoperability. We sort of think about our expectation for the way things work when we put our card into that ATM, and for the seamlessness and reliability of that. And then we think, let's just think about intake at our next medical visit. Well, tech is coming to us as well. The forces are long established. HIPAA was actually data standardization and billing standardization legislation. And the part of HIPAA that we think about, which is the privacy part, was put in there to protect the data standardization. That was the real goal. And then, of course, high tech and meaningful use. And the marketplace is starting to pick up on that. This is just a quote from an article in Modern Healthcare looking about Cerner trying to get a big military contract, and they're proposing as their distinctive capability to get this big military contract their ability to do predictive analytics, and this is in healthcare. So it is inevitable. New York's all-pay database, and Shin has the biggest bet that anybody has made in the country in the utility of big data in healthcare. So the premise of this again is you're a cancer patient in Chautauqua County ending up with a specialist that's Mount Sinai in New York City. You don't have to bring your data because it's in the system, and your doc at Sinai can access it. That's the we're a long way from that, but that's the bet. A big bet on big data. Now, on the one hand, it's inevitable. On the other hand, everybody who loves their EHR vendor raise their hand. So this is some painful stuff. Here's a study or something that was Open Minds, the behavioral health newsletter. That was a report from actually a report that they made a little bit more palatable from an article in the New England Journal of Medicine that looked at measurement approaches, and they found 1,000 different measures in 20 different systems with something like 20% overlap of measures from one system to the other.
I know you might find it hard to believe.
Thank you. Well, now you can hear. So, so measurement fatigue is a counterforce to all this. An article from Modern Healthcare where somebody did a study where they looked at the big hospital rating systems, Leapfrog, US News and World Report. I can't remember what the other ones were that they looked at. And basically, they characterized these. So these are consumer-facing, reports of quality they found extreme disagreement, with something like 15% of the hospitals that were in the top quadrant in one system also appearing in any one of the other. And a very high percentage of hospitals, high quadrant in one, worst quadrant in another. So, we may be moving toward the ability to use this data and access it ourselves, but we are certainly not there yet. And there are particular issues with respect to data in the behavioral health space, and I think the same thing is true in disability work, where we're so focused, we had the question before, we're not on the outcomes. We know it's good because we like it so much, and people depend on us so much, and what would we do without it, and it's about the relationship. It's a challenge. And we have the privacy laws, but more than the privacy laws, we have the confidentiality hang-ups, where our unwillingness or inability to share medically necessary information because of HIPAA, or because we didn't ask. So the hang-ups are a big problem. And a really significant challenge also in the EHR world is the fact that the EHR vendors in the specialty space, the mental health space, I assume the same thing is true in spades, in the disability services space, are not the same vendors. It's not Cerner and Allscripts and the Epic, those guys, where hospitals are dominated by big vendors who have marginal capabilities to integrate specialty data. Or they can do it, but it'll cost you a lot of money and it'll be painful. And then the specialty world is dominated by a whole series of one-off companies, all of which are small, most of which are oriented to selling you a system and they're not servicing it very well. And the two don't talk to each other. So this is another challenge as well. So the HIT data stuff is inevitable on the one hand. On the other hand, it's a bumpy, winding road, and it's going to be hard to tell how to get there. The third megatrend that I'll skip over pretty lightly because that's probably less focused on our needs here has to do with the emergence of precision medicine. And we do love science, and science rules, and science is driving all this stuff. An example of this at the federal level is that the National Institute of Mental Health, which funds mental health research, basically doesn't fund studies anymore that are interested in improving treatment for depression or schizophrenia or anxiety disorders or illnesses, because they've concluded each of these diagnoses, in a sense it's like cancer, is a grab bag of very different conditions with very different epigenetic causes that are likely to require, multiple solutions. So their research domain criteria approaches show us the underlying biological mechanism that's relevant to the study that you're about to investigate, and then we'll talk about thinking about interventions that might be effectiveness. This is a whole different world. There are beginning to be sightings of the precision medicine stuff in behavioral health, like an algorithm that people in the VA have developed, another approach at NYU where they can look at 28 different risk factors of your exposure to stress and so on and predict the emergence of PTSD. These guys talk about developing an avatar for precision medicine in psychiatry. And I just sort of have, as a sign of where this is going in healthcare more broadly, this is a little citing. This is an article in Modern Healthcare on July 4th of all things, so probably not everybody read it. An interview with a physician, Dr. Patrick Soon-Shiong, who, I don't know how old he is, but he's not that old. He's already sold 2 biotech startups for $9 billion. And his new company is called Nant Health. And what they're doing is they're putting like machines in hospitals and in oncology practices. He says his machine is now in 80% of oncology practices. So the way it works is if you come into an oncology practice with breast cancer, we do, your full genetic workup, and then we inquire for all the clinical trials that have been done in interventions of people who have a cancer and that genetic workup. And they might find effectiveness in prostate cancer. They might find effectiveness in pancreatic cancer. So we would never do this before because we were focused on breast cancer. But what they're finding is the ability to find an intervention that worked with somebody with almost exactly your genetic makeup is cutting through all these trials. And a part of this system is the ability to facilitate enrollment in clinical trials close to you. So, so they founded this company. Their next play is to invest in a number of large health systems to build this into the system, to try to grow the database. And he and his wife are going to make 8 or 10 $100 million gifts to health systems that buy and build in this technology. So this stuff is coming, and it's pretty big. But once again, there are cross currents and crosswinds. The standards that we have, which are not that precise, are under fire. This is a headline from the New York Times of a story with criticizing one of the most common measurements or guidelines, which is 30-day mortality rate for patients who undergo surgery. And they talk about the case of somebody missed by that, a 94-year-old woman convinced to get an elective bypass, who never made it out of the hospital and died on day 31. So, the standards have got to be a little more precise to work. Of course, in mental health, we remember this because of the much hyped introduction of these new meds, particularly the atypical antipsychotics, that was supposed to be, so much better and so much less in terms of side effects. And now we find out, 15, 20 years later, after, the patents have been run and the billions have been earned, well, not so much better. And actually, the side effects are just as bad. They're just different side effects. You gain 100 pounds and you're going to die of diabetes, but you don't have extra EPS symptoms. And then a very different approach to this whole challenge is from Jane Brody, the health columnist from the New York Times, whose stuff I love. Like, she's a couple of years older than me, but like, she was a Cornell communications grad, so I've always read her stuff. And this was a wonderful article where she talks about going to the doctor's office, getting the questionnaire to fill out, and the first question is, what's your general health? She says, I always check healthy. But then, like, all of my stuff is falling apart. Knee replacements and all this other kind of stuff. But she thinks of herself as healthy. Well, the same is true with a lot of people with disabilities and other conditions. I know a lot of people with serious mental illness that are more mentally healthy, right? In terms of an ability to manage their lives and their attitude about themselves and their relationships with other people, a lot of us allegedly normal. But this is a different perspective on what health means. This is a personally defined approach to health, not an outcome measure defined approach. I thought, this is one interesting thing that I found in looking for sort of evidence about precision medicine and genetic testing with respect to intellectual disabilities. And so it was data on the rates of testing for Down syndrome in pregnant women, which have gone from 25% of all pregnancies tested back in the early 80s, which would mostly be for women, over 35. To today, in this study, 75% of women getting testing. So a lot more people are getting testing. What decisions are they making about the pregnancy? Well, it turns out that the number of pregnancies that are terminated remains high. It's 75% today. In the early 1980s, it was 10%. In other words, although the rate is still small, there's been a 250% increase in the percentage of women who find that they're carrying a Down syndrome baby who go forward to delivery. This, cuts in lots of different ways, and the improved supports, the reduction of stigma, that are clearly changing people's calculus about all of this. So once again, precision medicine is a bumpy road. And the last of these big megatrends is the one that Jason spent most time talking about. And so I don't have to do this because we've already established that it's inevitable. The plan's won. They've got the money. As a therapist friend of mine used to say, it's okay to want that. Or you could say, it's okay to not want that, but forget about it. We're living with this different reality. Jason's quote, again, what's interesting is if you go back and look at those acronyms that I put up there, or the ones that Heather had, how many of those include some aspect of a different payment approach based on a different way to organize care? A lot of them, even ones that don't have to do with managed care. So now we're in this environment, and Jason painted it for us, of where everybody's going to be in managed care, and then managed care becomes the platform for these new payment approaches. That really accelerates things. Secretary Burwell's article in the New England Journal of Medicine, and then the New York State value-based roadmap. But as we've already indicated, as the conversation has already gone on, there are both possibilities and problems with all this. This is one of the possibilities. Lots of money is being spent in healthcare because of inadequate behavioral health care of people who have medical problems. But it's a problem so far. The first year or two are in on those Medicare ACOs. How's that working out for you? Well, it was a mild success, I guess, a mild success. Some people dropped out. Some people were doing too well before they started, so they're penalized for doing too well before they started. Other people can't make the improvement needed to make this work. And the question of how IBD, mental health, and addictive disorders fit in this brave new world is a big question for us. Do these services or populations become an unwanted cost center, or do they become a contributor to value? I can see in the mental health space how both can be true. The separate mental health clinic finds it inevitable or impossible to survive as a break-even proposition and goes away, while better behavioral health care in the primary care setting improves people's ability to manage their diabetes and improves their overall health and reduces expenditures. So which of these trends is it going to be? And none of us know what to do about this approach. So, once again, a megatrend, it's inevitable, but the speed at which it plays out is uncertain. So, a couple of thoughts at the end about how do we cope with all this. This is a little bit of inventory of major coping strategies. There's no place to hide from this stuff anymore. So, denial, or can we just go back to the old days of, cost-based reimbursement? No. It's over. It will not happen. It is dead. Might not be nice, but that's the way I am reading the tea leaves. So denial is not a great strategy. There's a different variation of denial, of course. It's easy for me to see because I've got 2 years left. This organization can make it for 2 years, and then I'm out of here. Which unfortunately, given the age of some of us in the management workspace, some of that sometimes it's more unconscious than explicit like that. But denial, not so good. This is not going to go back in the box. At the other extreme, panic. is not that helpful. A little bit of it to get an edge. Like, first of all, you might not be able to avoid it anyway, so it's not like we exactly have a choice about this. But a little might be appropriate. But a lot of panic is not really helpful. Which then goes to, okay, more mid-range appropriate alternatives. This is another one that's really dominant. The consultant of the day, the answers, the solutions, the going to meetings, the networking frantically, the Google searches at 3 in the morning, all those kinds of things. And there's a trap for those of us in leadership positions in this regard, because our staff want us to do something. If they're getting frantic too. Some of that is, maybe most of it is our franticness being passed on to them. That wouldn't probably be that helpful. But, so decisive action looks good. And if it works, it might be good. What are the chances that decisive action in a context that's so unpredictable is going to work? Probably not a great strategy. What about that? And so I have this counterintuitive approach to the whole thing, which is that a really good organizational strategy, I think, not the only organizational strategy, but a good organizational strategy in the context of all this uncertainty, is to apply the lessons that are really clinical lessons about resiliency. The human ability to cope with adversity is now sort of a proven scientific thing that probably explains why some people who are exposed to trauma get PTSD and some people don't, and it explains why some people who live with crippling disability are well organized and happy and giving, and other people with mild disability are crotchety, a pain in the butt, and obnoxious. So something about attitude is really helpful in that regard. Well, it turns out that this is not just a clinical phenomenon. It's not just something that's recovery and resiliency, not just in the mental health space. So this is a full issue of Harvard Business Review on organizational as well as personal resiliency. So here's a reference for the lead article here. And what's the big idea with this approach? It's this notion that, in a sense, this is what allowed some people to get through the death camps, accepting the reality for what it is, and then moving to what are we going to do about it, is more productive than griping about it all the time. And there are some characteristics to this. One of those characteristics has to do with having a belief and a commitment in the mission and the vision and the values that are not a lapel pin, are not a sign over the C-suite, but are something that everybody in the organization sort of understands we stand for. It turns out that kind of value set is something that it doesn't solve all the other problems, but it creates a capacity that makes it much easier for people to get through these other challenges. And the limited research that exists in this realm finds that resilient organizations practice this term that I'd never heard of, bricolage, which I think is actually partly it's a term from dance, which it means it would not, as my wife could say, does not apply to me. But bricolage means we solve the problems that we have with the resources that we have available to us. And we're creative about how we deploy the resources that are available to us, as opposed to, we try to go out and buy new ones, or we try to import solutions from anywhere else. So my sense about this is that, just to reinforce, we're in this environment of change that it just is and is going to be unpredictable, but it's going to be intense. It's not going to go away. And my sense about how to get through it is to spend time on organizational resilience. That starts with our relationships with each other in the organization that we're in. Strength there is a tremendous asset. Something else that is really critical is managing the basics well. So paying attention to margin, paying attention to costs in a way that is not frantic, but builds capacity over time. And so one of the things, that somebody may throw something at me when I say this, but what came to mind about this transition in DD that we're going to go through, of taking 2 steps backwards to get into this, this like weird fee-for-service thing before moving fast forward into value-based payment. That's an opportunity to get on top of costs. I don't mean get on top of the costs in the sense of control. I mean to get on top of costs in the sense of really understanding what we are investing in and how we organize what we're invested in. Communicate across the leadership team. I'm reminded in this regard of a great book. I may not remember the title of it. That is probably about 20 years old, by a guy who was an exec at a Canadian steel firm that got caught in organizational change at the same time as they got hit by a recession. And this very successful family-owned firm barely survived over the next 20 years. And this guy, after moving on, decided to try to figure out what made them survive, to rethink his own journey. And that led him to research what had been successful organizations, which led him to the story of the most resilient, longest-lasting human civilization in the history of the world, which is the Bushmen of the Kalahari Desert. It's a society that is almost completely destroyed by the advances of, the modern world. But it's a society that survived for 40,000 years. Hunter-gatherer approaches, which is a strategy to live on a land with very sparse resources. So groups would spend most of their time wandering around, making a living off the land, but would always come back to spend time together at an improvised village, where relationships would be formed, stories would be told, culture would be passed on, and this image of this balance between exploration, finding out what's out there, and then coming back and talking about it and making sense of it, this guy said was, although he didn't realize it, what got his company through these challenges over time, this balance of structure and rigidity. We're not going to be able to control our way through this environment. And, again, it's okay to want that, but it's not going to work. We're going to have to balance innovation and flexibility. And finally, this notion of making smart incremental bets that fit both internal capabilities in the emerging environment. And without knowing too much about it, I really like what the Resource Center is doing with the STARS approach in this regard. It's a bet on adapting and improving things that you're already doing, that in a way that ought to be both good for patients, and if this value, payment stuff plays out the way it's supposed to play out, who knows if it will, that will be a structure of integrating care and delivering it together and building the physical environments for it and building the IT environment for it that ought to help you succeed. So that is, I think, a great example of a smart bet. And then, finally, of course, and this is hokey as hell, but it really is true that the biggest. I'll go back to bioscience here and studies of the effectiveness of health intervention. What is, across all dimensions of healthcare, the consistently most effective intervention that we have? Placebo. Across all healthcare conditions, placebo averages out about 35% effectiveness. And so, optimism, resiliency, organizational placebo, in a sense, is a very powerful innovation, which is ours to control. So the grumpy leadership is not going to win in this chaotic game that we're dealing with. So I hope that that was a little bit of digestive, as I said, from everything that Jason threw at you. There's no answer in this. I think there's an affirmation in that for some of the things that you're doing that I think might work, and it leaves me with this closing thought. It'll be awesome, and good luck. Thank you. Now, one of my tactics as a speaker is always to go until there's no time left for questions. But there are so many questions for Jason that the time has worked out all right. But just in case there are a couple before we break for lunch, anybody have any?
I loved your what really matters slide that you concluded with, and making smart and incremental bets. Reflect on that when Jason lost this, but obviously he said, throw caution to the wind, come with me on the journey, let's jump. Right?
Right. Well, I think it's a both and proposition. To interpret what he said in a different way, and maybe in a year in New York State we'll have like more big plays and acronyms. But I'm not sure that I bet on it. I think that with the managed care stuff and with district and with what they've already signaled with respect to value payment, I think there are going to be detours and there are going to be roadblocks. But I think that's the game. So where I go in that regard is to wherever we're at today, anticipate stage 2 and 3. So, and as I said, that I know very little about your programs and services out here, except for a few conversations with people. But from the limited amount that I found, I really liked the Resource Center's approach to the STARS investment thing. I see that as catalytic. It's a mid-range kind of bet. It's not betting the company, but it's significant, and it aims at both better care. And it aims at an environment where you might succeed. So, a different way to think about it. Stephen Covey's 7 Habits. I sort of think about 2 of his habits that come to mind in this regard, and not one of them. I'm not sure if these are the first 2 in order, but begin with the end in mind. We sort of have to have a sense of what not the terminal end, not that kind of end, but begin with the goal in mind. And then the other one, of course, this is like a contradiction because it's the polar opposite, is this principle about first things first. So this notion of beginning with the end in mind, but then thinking about realistically where we are now, having that end goal in mind and taking the steps that we can take. I mean, it's not an answer, it's more like a mindset. One more question, if anybody's got one? Instructions for lunch?
I'm on it.
Cool.